Good afternoon, everyone. I'm Vahan Kassabian. I'm a urologic oncologist with Advanced Urology Institute of Georgia, and I'm right here in the north side area, including Alpharetta. Today, I've been asked to speak to you on new treatments in localized and advanced prostate cancer, and you can see my full disclosures on a prior slide. I've been in the community now for almost 30 years and happy to be here and happy to be back at Northside doing my major surgeries. Today is really twofold topic. I'm going to talk to you about a new treatment that I've been doing for about 15 years now. It only got approved by the FDA probably about 5-6 years ago now. And I'm going to talk about my other passion, which is treating men with advanced prostate cancer. So I got interested in HIFU, which is high intensity focused ultrasound, probably about 15, 16 years ago. And after doing a lot of surgeries for radical prostatectomy for clinically localized prostate cancer, I figured there was probably a better way to do this. And of course, we went from open techniques, which is what I was trained in, which I still perform, to robotic, which I personally didn't like. And so I started to do and think about ways I can treat prostate cancer, and I stumbled upon high-intensity focused ultrasound. Being originally from Montreal, Canada, and having my license up there, and it was approved in Canada, I would take my US patients, treat them in Canada, and bring them back here to the US. Since the FDA approved the treatment for prostate ablation approximately 5-6 years ago, I no longer need to do that. So I do all my surgeries here locally. So high intensity focused ultrasound. It's an interesting technique. Well, let me give you a little bit of demographics. You're probably all familiar with this. Prostate cancer, of course, is very common. It's the most common solid tumor in men in the United States. It happens to be the second cause of cancer death in men in the United States. So it's both very scary and confusing at the same time. We need to do a better job of identifying those patients who are potentially have indolent disease or intermediate risk versus those that have high grade risk and are destined to fail, have metastases, and potentially die of their disease. Because it's so common, we didn't have the tools that we needed back when PSA became popular in the 1990s. And you're all familiar with the PSA controversy. We went from an increase in prostate cancer incidence to over 200,000 cases a year based on PSA, but we realized we were probably over-treating some men that didn't need to be treated. They had indolent disease, but we did not have the tools at our disposal. We didn't have genetic markers. We didn't have pathology markers to help us identify which tissue is more indolent, which tissue is more aggressive, and to weed out the ones that are more serious versus the indolent cancers. But because of all this, the US Preventative Task Force sort of gave us, I'm sorry, I'm having some technical issues, but I'll continue to speak, gave us PSA sort of a bad rating, and PSA use in internal medicine went down drastically since the 2012 recommendation. But unfortunately, what we've seen now is an increase in the presentation of patients who at diagnosis of their prostate cancer present with metastatic disease. And that's unfortunate because before the PSA era, it was 25%. Since the PSA era, that went down to less than 10%. Granted, we were over-treating some men who didn't need to be treated, but by stopping the PSA, we sort of shot ourselves in the foot, and we saw an increase in the incidence of men presenting with metastatic hormone-sensitive prostate cancer. So there's a happy medium there to try and figure out who has indolent disease and who does not. So I think this is where HIFU sort of comes into play. So as I said, 1 in 7 men will get prostate cancer. Let me see if I can go back to my slides. I apologize. Technology is great when it works. Let me see if I can just try and fool this a little bit.
Dr. Kassabian?
Yes.
Yeah.
I think the only way you're going to be able to fix this is to close it out and open it again, or you can just advance, each slide right now like it is.
Okay. Let me do that because I have a feeling I'm going to continue to have problems.
Okay, sure.
Thank you. All right, so what is needed? We have to do a better job of trying to figure out who has indolent cancer and who doesn't. So I don't know if you're familiar with the New England Journal of Medicine article came out in October 2016, where in the UK, they randomized, well, not really randomized, but they sort of did a retrospective review of patients who were placed on active surveillance versus surgery versus radiation therapy in those men who had clinically localized prostate cancer. And the patients who had nothing, who had active surveillance, their cancers continued to progress. And nearly 20% of the active surveillance patients got treated within the first 2 years. And more than 50% received treatment within 10 years. And this is in the UK where they're very conservative with their PSA screening and treatments of prostate cancer. Active surveillance patients had 6.3% rate of metastatic disease, more than double that of radiation or surgery. So it really depends on what your outcome was. And the quality of life on those patients who had active surveillance and progressed, who had nephrostomy tubes, renal failure, was significant. So there's a balance between screening and treatment. I think not doing a PSA is the wrong answer. I think deciding who needs treatment and who needs active surveillance is a better approach. Some have even suggested that lowering the PSA to 1.5 is probably a better cutoff than the 4.0 that we have. We also have age-specific PSAs, which are also helpful. We also have other tests that we can do. For example, we can look at 4K score, which is looking at 4 different callicrins of PSA and trying to determine statistically what the probability of having high-grade prostate cancer is. We have other genetic markers. We have lots of tools at our disposal. We even have MRI, which in the US is not used for before a biopsy to screen who should have a biopsy. That's what's done across the pond. Here we use it in the staging of prostate cancer once the diagnosis has been made. But we have all these tools at our disposal to sort of figure out who needs treatment and who doesn't. So you have all these extremes, right? You have active surveillance, and then at the very end, you have surgery or radiation for your patients that really need aggressive therapy. But there's a happy medium for these patients who have intermediate risk prostate cancer, who don't want to be on active surveillance, who don't want surgery, who don't want radiation. There's a happy medium. And I think this is where high intensity focused ultrasound comes into play. It has reduced side effects. It's outpatient. It's a one-time procedure. It takes about 2 to 4 hours to perform. They have a catheter. We basically use heat to destroy tissue. So it's an ablative therapy, just like radiation, just like cryo, but it's using heat, and the energy source is ultrasound. So it's this high intensity focused ultrasound that we zone in to the prostate. And if you remember, it works very similar to when you were a child and you took a magnifying glass to sunlight and can burn a leaf. Well, it all depended on the focal distance. If you were too close to the leaf, nothing would happen. If you were too far from the leaf, nothing would happen. It has to be just the right distance, and that's called the focal length. So this is important because prostates that are too large, or if the lesion is too far away from the rectum, I cannot reach it with a probe. So therefore, I have to find ways to shrink the prostate or bring the lesion within the field of treatment. So this is important. And The nice thing about HIFU is I can treat as little or as much of the prostate that I deem necessary or that the patient and I agree on. Obviously, the less I do, the less side effects they're going to have. But even with total gland HIFU, the side effects are pretty minimal. It is performed under anesthetic, and for example, focal therapy can take me less than an hour or certainly less than 2 hours, and patients go home the same day. They do wear a catheter for 5 to 7 days. The concept, though, of focal therapy in prostate cancer has not quite caught on in mainstream urology. We do have data. We have published data here in the United States that are very promising. But the analogy I like to give is prostate cancer is very similar to breast cancer in incidence and its hormonal dependence. They both occur in secondary sex organs. They're both important for either reproduction or lactation, for example, in women. So they're very similar biologically and oncologically. So as we evolve from radical mastectomy to lumpectomy for breast cancer, I think we're evolving for certain patients from total gland therapy, whether surgery, radiation, or total gland HIFU, to focal or hemigland ablation. And we do have very good clinical data. We have negative biopsy rates in multiple trials, both across the pond and here in the United States, where focal or hemi ablation seems to have an excellent cancer control while maintaining sexual and urinary function. So this is the way I sort of want you to think about HIFU. It's a bridge between active surveillance and more radical surgery or radiation with the potential side effects of each one. So if we look at some data that was published in disease-free survival rates, retained sexual function, and maintained continence, you can see here with focal ablation has the highest rate of preserving side effects. Full gland is excellent compared to surgery and radiation. So it's very well in line. Most of the initial data was published in Europe in the Journal of European Urology in 2018, which was a 5-year study of over 625 patients with excellent cancer control and quality of life. And quality of life measures were actually looked at as well in multiple trials. And you can see that the pad-free and preservation of erectile function is very high with HIFU. Here we had another publication in the British Journal of Urology in 2019, which showed, again, from more patients, over 1,000 men, very similar control rates and preservation of quality of life and sexual function. And then we finally had publications here in this country, in the US, in our Journal of Urology, and last year in October, and we just had one recently published about a month ago, which I didn't have time to update on the slide presentation. But again, this was on focal or hemigland ablation, and it showed excellent cancer control at 2 years, and this was at a reputable academic institution out west. So if we look at now, let's switch gears. So we're moving away from HIFU, which is a treatment option, minimally invasive to treat localized prostate cancer in those patients who are good candidates. Now let's fast forward to the cancer has progressed and is now in an advanced stage and has possibly spread to either bone or lymph nodes or other organs. And this is my other passion. So if we look at the historical developments in prostate cancer, you can see that the first surgeries were done over 100 years ago. And then we slowly start to develop these medical therapies. In fact, the Nobel Prize in Medicine was awarded in 1940 to Huggins and Hodges for their use of surgical orchiectomy in the treatment of prostate cancer. That's when we realized this is testosterone dependent. And then we had LHRH agonists come into play, such as Lupron or Leuprolide or Eligard. And again, the Nobel Prize was awarded to Shally and Guillemin for their findings. So most patients now don't have a surgical orchiectomy. They have what we call medical castration along with these drugs. These LHRH were agonists. So what happened was you'd create a surge in LHRH it would create a flare of the tumor and a rising PSA before LHRH production decreased. In 2003, we had the first GnRH antagonist come into play, and now we have the first oral antagonist on the market, along with another one that's available in a subcutaneous dose monthly. So we can manipulate the production of testosterone, of androgens, to our benefit to starve the body of testosterone and hence starve prostate cancer. Along with these therapies, we have oral therapies that came into play to work on the end organ. So the LHRH agonists or antagonists decrease the production. Then we have the antagonists. We had first generation like flutamide, bicalutamide. These stop the effect of testosterone on the end organ. Nowadays, we have second or third generation anti-androgens, such as apalutamide or enzalutamide or darolutamide, that are much more potent in their activity. And we use these oral therapies in advanced prostate cancer along with LHRH therapy. LHRH therapy is the foundation. Adding these medications help have the benefit of whatever testosterone or androgen is left circulating in the body, the end organ effect is blocked. We also have abiraterone, which also can cut down on the production of androgen from other sources other than the testicle, such as the adrenal gland. So let's talk about some of the definitions. ADT, androgen deprivation therapy, sort of encompasses LHRH antagonists, agonists, or surgical castration. Metastatic, I'll use spread to bones. Non-metastatic, CSPC. This is a terminology that you as internists may not be familiar with. It's castration-sensitive prostate cancer. So the tumor has never been exposed to androgen deprivation therapy or is still responding to the androgen deprivation therapy. Castration-resistant prostate cancer, CRPC. Cancer is growing, PSA is rising despite serum testosterone levels of less than 50, identifying this patient as being castration resistant. So the tumor has found a way, usually by mutations, to use the little androgens that are left to its benefit to feed its tumor. HRR is a new terminology that came into play more recently. It's homologous recombinant repair. And remember, I mentioned the similarity between prostate cancer and breast cancer. Well, we now know a lot of the genes that predispose a woman to breast cancer, such as BRCA1 and 2, are also responsible in some men for causing prostate cancer. So in our workup, to our patients, it's no longer, do you have a family history of prostate cancer? Do you have a family history of prostate cancer, breast cancer, pancreatic cancer, colon cancer, to sort of cover not just the BRCA1 and 2, but also the other HRR mutations. So the little m, MCSPC, NM, CRPC, M, CRPC, M stands for metastatic, and NM stands for non-metastatic. That's the disease state that they are in. So this is one of my favorite slides. It shows you a roller coaster ride of what the journey of prostate cancer can look like. So first you have primary therapy, surgery, HIFU, radiation, active surveillance. You can have biochemical relapse or recurrence. Then eventually these patients can get placed on ADT therapy. They have a good response, their PSAs come down, but then their PSAs begin to rise, and that's considered castration-resistant prostate cancer. So it's when they're no longer responding to hormone therapy, ADT, that their tumors begin to rise and they're deemed castration-resistant. So this is a very important graph. And on the left, where you have castration-sensitive, the side effects tend to be whatever the side effects are of the therapy, of the local therapy. When you put these patients on hormone therapy, we literally accelerate the aging process. We're causing andropause similar to women going through menopause. So it's a life-changing treatment. They begin to have hot flashes, weight gain, increased risk of osteoporosis, increased risk of cardiovascular toxicity. So we have to address bone health by putting them on calcium supplements, vitamin D supplements, and we have therapies to increase bone health and decrease the rate of osteoporosis, such as denosumab or other therapies. So it's very similar to what happens in menopause and what we cause in andropause in men. This slide is not going to show up. This was a build-up slide, so I apologize. But basically, if you look at the bottom, you have these 4 buckets. You have metastatic castration hormone-sensitive prostate cancer. Then you have non-metastatic castration resistant. In other words, ADT is no longer effective. PSA is rising. We image them. No evidence of metastatic disease. Or we image them and they now have metastatic disease and they're castration resistant. And then we have at the very right, we have this small subset of population of patients who have HRR mutations such as BRCA1 and BRCA2. So let me start on the first one, the metastatic castration hormone sensitive space. You have enzalutamide, you have apalutamide, and then you have, these are the androgen receptor blockers. And then you have abiraterone, which is an androgen production inhibitor from the adrenal glands. Again, you're continuing to have these patients on the androgen deprivation therapy, so which is the foundation. And then you have taxotere, which is a chemotherapy agent. So all these have been approved to improve not just overall survival, but also improve progression-free survival. Then the second bucket is non-metastatic castration-resistant prostate cancer, and we have 3 oral anti-androgens in this bucket: enzalutamide, apalutamide, and darolutamide. The third bucket, we have metastatic castration-resistant prostate cancer. We have Supilocel T, which is an immunotherapy. Then we have enzalutamide. We also have abiraterone. We still have taxotere. But now we have radium-223, which is a radionucleotide that's a once monthly IV infusion for 6 treatments to selectively attack cancer that has bony metastases. The last bucket is for those mutations. We now have genetic testing through tissue and through blood to identify these either germline or somatic mutations. In other words, are these passed on from generation to generation, or are these somatic mutations acquired during the progression of prostate cancer? And we have 2 therapies that have been approved in this space that specifically address these mutations. I was fortunate enough to be a co-author on a paper that was published in Cancer about a year ago, and it was real-world outcomes of Supilocel T treatment, which is immunotherapy, which was a prospective registry of men with metastatic castration-resistant prostate cancer. And we learned a lot from this, that patients whose PSA are lower when they have mCRPC or castration-resistant prostate cancer seem to do better. And we also learned something interesting, that African-American men in this registry did far better than Caucasian men with this advanced prostate cancer, even though this cohort of African-American men had a PSA that was a lot higher when they received their immunotherapy in the form of Supilocel T. Very interesting. I can't explain the rationale other than perhaps the immune system is different in African-American men versus Caucasian men, but this was shown in the study, again, despite these men having higher PSAs at the time they received immunotherapy. So very interesting data. Let's talk about the genetic mutations. The most common ones are the BRCA1 and 2 and ATM, which 12% happen because of germline mutations, and another 15% happen in somatic mutations. This is really the newest treatment that we have, and we've had this now for less than a year, and it's specifically for these men who have these HRR mutations. Each of these drugs have different indications and contraindications. I'm not going to get into that, but it's really a very interesting topic. The NCCN, which is the National Comprehensive Cancer Network, which is sort of the body that I follow, recommends germline testing and somatic testing in men who have high risk or very high risk prostate cancer, who have an Ashkenazi Jewish ancestry or have a family history of higher germline mutations in the family, or Lynch syndrome, for example, or positive family history of these different cancers. So the NCCN recommends genetic testing for all these patients to find these, cohort of patients that may be eligible for these PARP inhibitors, which are very specific targeted therapy. Advanced prostate cancer and moving the needle to have better therapies for these patients really is at the source of understanding the different mechanisms, immunological, dietary, genetic, environmental, to sort of play with these targeted therapies. And these are the novel approaches that we are looking into now. If you compare prostate cancer again to breast cancer, we are 20 years behind where breast cancer is now. We've been using these mutations in BRCA1, BRCA2 to the benefit of the patients with breast cancer for a very long time. And we are just learning about this in prostate cancer. So we're a little bit behind, but we're definitely catching up. Happy to offer my services at Advanced Urology. The phone number is here. A lot of you probably have my cell phone number and can reach out to me. I'll be glad to take any questions from the audience at this time. And again, I apologize for the technical difficulties, but I think we made it work. Thank you again.